So this one, I mean, I had a look at the comments as well, so I kind of know what someone has said it is. But when you see this, hopefully you can see that there is something clearly abnormal located within the right lower abdomen. And so some people may say that, oh, well, this could be a collapse of the lung. It could be a collapse of the lung, yeah, maybe, I suppose so, but it doesn't have the other findings of a collapse of the lung. When you're saying collapse of the lung, you've got to think, okay, is it tenting of the diaphragm, hemidiaphragm? Does that look tented? Not really. That looks very, very flat. But yeah, you do have a bit of blunting of that costophrenic angle. Look at that costophrenic angle compared to that one. So that is some fluid within that right hemithorax. But when you've got this lesion sitting over here, also the things that don't tell you that there's going to be collapse or anything like that is that the hila look very, very central. It doesn't look like it's particularly raised. There's no crowding of the ribs. So the ribs actually look pretty equidistant and almost identical to the other side as well. So we're not looking at loss of volume here. So what we're looking at is actually some sort of added volume, something added here. So when you look at this lesion, so if this is like any other, what you can see is that it kind of becomes a bit ill-defined as you get to the outside of it. So when you've got an ill-defined aspect to a lesion on the lateral aspect of the lesion, then you're probably looking at something that's going to be pleurally based. That's kind of one of the telltale signs of something that's pleurally based rather than intraparenchymal. And you'll see this like with pleural thickening, with fluid. Sometimes you get loculated fluid within the pleura, and that can result in sort of ill-defined lateral border. Ill-defined lateral border is a good way to know that this is more likely to be pleurally based rather than being intraparenchymal. Now, the other thing that people may wonder is this going to be a neurogenic lesion? A neurogenic lesion would be coming from the actual sort of from the exiting nerve root foramen. So you can actually see that there's really not much in the way of involvement of the interneural foramen. There's no widening, there's scalloping of the vertebra within that region. So less likely based on these findings. Someone's very helpfully done a lateral view. And again, you can see the sort of fluid looking area sitting over here. And you've got what looks like a very well-defined lesion located in the posterior aspect. So when you've got a lesion that is sitting like this, you've got that sort of ill-defined lateral border, you've got a bit of fluid located with a costophrenic angle. I would be going for where this is more likely to be a pleurally based lesion. And when you say it's a pleurally based lesion, therefore this would be, this could be a loculated effusion. You can get effusion that are loculated. Sometimes you get fluid sitting within the oblique fissure. And I think in this particular occasion, they said this person was turning up with fevers. So when you've got fevers, you've got to be worried that, okay, fine, you've got fevers, then this could be something like an empyema. Most likely you're going to end up doing cross-sectional imaging. The reason you want to do cross-sectional imaging as someone who's got fevers is just to know whether they've got a potential, how big is this loculation and whether you can actually think about doing a sample, and you could do an ultrasound first if you really want to. But generally speaking, we'll just go straight for CT, see how big this is, look at how we could possibly get a sample from this and send it to the labs for finding out, what their patient could be, what antibiotics the patient could be susceptible to. So yeah, thank you very much for someone tagging me on that one.